It's unclear if atopic dermatitis gets worse or better in pregnancy. There was one study in the 90s showing that about 50% of women report that they get worse during pregnancy, their dermatitis gets worse. About 25% that report that their atopic dermatitis gets better, and the last quarter say nothing changes. But again, that data is pretty old. Atopic dermatitis during pregnancy falls typically under an umbrella term called atopic eruption during pregnancy. That includes both atopic dermatitis proper and other kind of eczematous pruritic diseases of pregnancy. This so-called atopic eruption of pregnancy is the most common pregnancy-related dermatoses, accounting for up to 50% of all pregnancy-related skin problems. There are several so-called pregnancy dermatoses, skin rashes during pregnancy, that are quite characteristic. The most common one is atopic eruption of pregnancy. Again, almost 50%. The next most common one is polymorphic eruption of pregnancy. The third and fourth and fifth are prurigo of pregnancy, intrahepatic cholestasis of pregnancy, and they all have very different clinical pictures. For example, polymorphic eruption of pregnancy is urticarial plaques that usually start in the abdomen or in the striae that are incredibly itchy, whereas atopic eruption of pregnancy is more typically just eczematous or nonspecific pruritic papules and plaques. The European Task Force just published a great guidelines paper on the treatment of atopic dermatitis during pregnancy. And just like in normal atopic dermatitis, really the mainstay of treatment is emollient therapy. So they recommend, and I recommend, up to twice a day emollient therapy use. Preferably one time with the soak and smear technique, where you apply the emollient to wet skin right after bathing. Wet wrap therapy is also possible if the patient will comply. The next step, if that doesn't work, is to add a topical corticosteroid, typically medium potency steroid, a level 2 or level 3 steroid, twice a day for up to 2 weeks. If that's not successful, or if you find that you're using more than 200 grams of the product in that 2-week span, then there's two options. You can either go straight to UV therapy, or you can try what's called maintenance therapy, where you use the topical corticosteroid 2 or 3 times a week and use emollients the rest of the days. And if that doesn't work, then you're stuck with UV therapy. For UV therapy, there's a few options. There's narrowband UV therapy, and there's UVA therapy, and then there's broad spectrum UV therapy. In our practice, we typically recommend narrowband UVB therapy. It seems to work very well. You can do that 2 to 3 times a week. And in combination with steroids, I think that controls symptoms for 99% of women with atopic dermatitis during pregnancy. In the few remaining patients, if the UV therapy and the emollient therapy and the topical steroids aren't enough, then you have to start talking about systemics. And there's not great options for systemic anti-inflammatory medications during pregnancy. Probably the most commonly used is systemic corticosteroids. And the current recommendations are you can use about 0.5 milligrams per kilogram per day of prednisone or prednisolone for up to 2 to 3 weeks. And in some cases that might be necessary. The other two options for systemics during pregnancy are azathioprine and cyclosporin, both in data from either transplant patients or data from inflammatory bowel patients. There doesn't seem to be an association with any birth defects or abnormal birth outcomes, but it's still not recommended. If the woman's on azathioprine prior to getting pregnant, the current recommendation is to decrease the dose by half, and then hopefully with topicals you can control the symptoms. In terms of the newer systemic medications, we don't have good data for, or they're contraindicated. So right now there's an outstanding question on how many women with atopic eruption of pregnancy will continue to have symptoms of atopic dermatitis afterwards. Only about 20% of the women who get diagnosed with atopic eruption of pregnancy report a previous history of atopic dermatitis. So it seems like in the majority of women affected with this, that's kind of their first atopic dermatitis symptoms. We do know that there's a high risk to flare at the next pregnancy. Up to 70% of women who have atopic eruption of pregnancy in one pregnancy will have it again in the next. But in terms of how many of them will have atopic dermatitis generally afterwards is an outstanding question. So both clinicians and patients are sometimes wary of treatment during pregnancy. Granted, I think unnecessary treatment that has the potential to affect the growing child is it should be not considered lightly. Nevertheless, I think an inflammatory state like atopic dermatitis has its own side effects. So I think uncontrolled atopic dermatitis during pregnancy really deserves treatment. And I think topical emollient therapy and topical corticosteroid within reason is very, very safe both for the mother and the child. And so I encourage both clinicians and patients to not be wary of well-needed treatment.